Hi, I'm Darby Santiago, a clinical professor of retina surgery at the University of the Philippines and De La Salle University. Today, we shall learn how to recognize and classify diabetic retinopathy based on the features seen in color photos of the retina. At the end of this lecture, you should be able to distinguish whether a person with diabetes has diabetic retinopathy or not. You base this on the fundus photos. And if he does have diabetic retinopathy, you should be able to classify whether he is in the non-proliferative stage or in the proliferative stage. But for advanced students who would like to learn more about the sub-stages of diabetic retinopathy, there will be a separate training lecture module for that. Okay? Diabetes is a disease that affects an increasing number of Filipinos. It is a disease that leads to hyperglycemia or increased glucose in the blood. This hyperglycemia often leads to blood viscosity, increased red blood cell aggregation, and parasite loss in the capillary walls, and thickening of the basement membrane. All of these histologic changes have effect on the caliber and blood. During the first few months, 2 years of diabetes, the hyperglycemia will not immediately result to any visible changes in the retinal architecture. What you will see is the regular red-orange background of the retina shown here. This is devoid of any hemorrhages, which are red spots, or other discoloration. Yellowish orange disc with normal looking vessels pass through this normal retina. You also see smooth, regular, gradually tapering, and dichotomously branching veins. You can see the less reddish arteries with smaller caliber size, but equally smooth and regular like the veins. The vision in this patient should be about 20/20. This is the perfect vision. As the years pass of uncontrolled hyperglycemia, this will lead to microvascular changes. And showing in the picture here, you will see microaneurysm formation, the round small lesions there. These are actually the very first visible signs of diabetic retinopathy. If the microaneurysms are very, very small, you may not be able to see them. However, there's this large one there. You can already see that on examination or photograph. To the examiner, these microaneurysms will appear as tiny red dots that can be seen anywhere in the retina. It can be in the posterior pole in this area, or it can be in the periphery of the retina. These microaneurysms have very unstable walls, and they tend to allow intravascular contents to spill out from the walls. Blood should remain inside the blood vessels, not in under normal conditions. However, the microaneurysms reverse these features. Once outside the blood vessel, these plasma components, your cholesterol and lipids, they tend to accumulate and aggregate until they become visible to the naked eye, and we label them as hard exudates. Therefore, although they are not a direct effect of the hyperglycemia, hard exudates are a consequence of the microvascular changes that occurs in diabetes. At the same time, continued weakening of the capillary walls may lead them to burst with changes in intravascular pressure. This is perhaps due to a concomitant hypertension or due to the blocks created by aggregates of red blood in the blood vessels, leading to buildup of pressure inside them, and then you have it bursting out of the blood. The result are the formation of intraretinal hemorrhages of varying sizes and shapes, which you see as red areas scattered all over the retina. Like your hard exudates, they are not a direct effect of your diabetes. They are a consequence of the changes in the blood vessels, the weakening, the increased intravascular pressure. Now moving on. Further weakening of the blood vessels and increased sluggishness of the blood flow due to hyperviscosity can also lead to changes in the caliber or the diameter of retinal veins. In long-standing cases of uncontrolled diabetes, you see the veins as having sections that are dilated. No? They're not regular anymore. They don't appear straight and tapering. No? Some sections may have focal constrictions or narrowing. The term sausage-like veins are often used to describe these changes seen in the photo. So to summarize, the clinical features that are seen in early parts of diabetic retinopathy include your microaneurysms, the hard exudates, your blood hemorrhages, and your venous dilation. If you have these lesions in the retinal color photo of a patient with diabetes, then you are almost certain or sure that he has diabetic retinopathy, and he should be evaluated by an ophthalmologist at the soonest possible time. However, the changes does not stop there. With the continued block created by the viscous blood and erythrocyte aggregates or clots, capillary closure ensues. No? And as a consequence, when your capillaries are blocked, there is loss of oxygen supply to small areas of the retina. And this is what we term as ischemic areas of the retina. This is similar to brain stroke. When there's loss of blood supply to the brain, you get stroke. No? This one is a retina stroke of the retina. We just term it as ischemic areas of the retina. If the number of ischemic areas much larger than what is shown here in this photo, if there are larger areas and they accumulate over time, this will stimulate the production of vascular endothelial growth factor. Now, what does VEGF do inside the eye if the retina produces it? So the VEGF produced is released into the vitreous area of the eye, and this leads to the stimulation of the formation of new vessels. And the growth of new vessels heralds actually the transition from the non-proliferative stage to the proliferative stage. These new vessels, as you can see in this photo, they don't follow the dichotomous branching pattern of the normal retina. They are what we call unruly. They grow in any direction they want to. Often they have a varying caliber, and they seem to have grow in with no direction at all. So it is important, when you examine fundus photos, that you check for these blood vessels, because these new blood vessels are what you call the heralds the stage of proliferative proliferation. Over time, without the benefit of laser treatment and proper blood sugar management, the new vessels grow wild. They can spread across the retina, and as I said, they can grow into the vitreous, and they actually form fibrin membranes with them as they grow. This is what we call fibroproliferative membranes. And since the vessels in these membranes, the new vessels, they're actually false vessels and they are unstable, they are prone to breaking, and when they burst, they result into hemorrhages. The photo here shows both shaped hemorrhage because there is, as you can see, there's some leveling of the blood, no, uh, at the top, and this hemorrhage, if they are large enough, they can cause blurring of vision, such as this case. No? The hemorrhage here came from new vessels that has burst, and the blood has spread all over the vitreous. Uh, the patient, in this case, will experience sudden blurring of vision. These patients should be referred immediately to the ophthalmologist in order to salvage this patient's eye, and more importantly, um, the other eye of the patient should be lasered. Therefore, as primary care healthcare providers, our task is to detect the presence or absence of diabetic retinopathy among diabetic patients as early as possible using features seen in the color photo of the retina. Okay, as a review, um, for NPDR or non-proliferative diabetic retinopathy, we look for microaneurysms, uh, hemorrhages, exudates, vessel wall dilation, no, to venous changes, and when we go to the early proliferative diabetic retinopathy, we look for signs of new vessel formation or neovascularization. And when you have formation of fibroproliferative membranes and vitreous hemorrhage, this is already the advanced stage called high-risk proliferative diabetic retinopathy. Here is the summary again of what we have just discussed. And before we end this lecture, let us do some exercises. I'll give you 3 cases, and we'll try to identify all the lesions that you see, then give our final diagnosis. Okay, let's begin. This is the first case. It's a 55-year-old male, 3 years history of diabetes. Now you have a checklist over there. Look for microaneurysms. What you can see are really blood hemorrhages. Okay, they're the most prominent one. And then up there you will see, okay, and then up there you see hard exudates. Okay, meaning there are already leakage happening. So probably the photo is too small. Maybe you can enlarge it. Always enlarge your fundus photos and look for the small dots, which represent your microaneurysms. And here, superiorly, the vein appears a little bit more, um, dilated and a little bit tortuous. So you must let's look at the high magnification of that area there. There. So you see, no, when you thought that it was already in the non-proliferative stage at least, so you check on higher magnification, you see those new vessels there. So this immediately changes your diagnosis to the proliferative stage. And so you must refer this patient immediately to an ophthalmologist. Okay, let's go to the second case, a 60-year-old newly diagnosed diabetic who came in for blurring of vision. Newly diagnosed, okay, of the left eye, blurring of vision of the left eye. So you can check which lesions are present. No? Look at the list. What you see there in the middle is actually a clump of hard exudates. Okay, fine. But do you see microaneurysms? Do you see hemorrhages? No. How about vessel wall changes, like thickening of the veins. Okay, in the superotemporal part, there's a little bit of maybe some dilation. Okay, but what is amazing here is that peculiar. But is there no microaneurysms or no dot blood hemorrhage? No, all I don't see any neovascularization. No, so do we label this as diabetic retinopathy since there are hard exudates? Well, the answer is no. Why? Because remember, the first sign of diabetic retinopathy is the presence of microaneurysms. So without those, the source of the hard exudates must be from another pathology. It must be from some other like age-related macular degeneration, okay? But not diabetic retinopathy. And also, this patient is newly diagnosed. So he or she may not have features of diabetic retinopathy. Okay, so let's move on to case 3. Okay, 52-year-old female, diabetic for 3 years and hypertensive for 8 years. Okay, so what do you see here? From the photo, we see that the optic disc seems to be a bit swollen or indistinct, no? Unlike in the previous cases. There are surrounding flame-shaped hemorrhages. However, we see the dot blood hemorrhages of that is what we saw in diabetic retinopathy. However, here there's a more proliferation of your flame-shaped hemorrhages. Okay, there are no fibroproliferative membranes, no vitreous hemorrhage. There are some hard exudates like dot, no, that you see. Okay. So let's look at a more magnified view. There you can see some microaneurysms, and there is mild vessel wall changes. But try to look for abnormal looking new vessels. Do you see some? Okay, I agree. There are no no obvious new vessels. So I would say that this patient has non-proliferative diabetic retinopathy. However, the presence of the swollen disc and the predominance of flame-shaped hemorrhages will also tell us that this patient has a superimposed hypertensive retinopathy. Yeah? But hypertensive retinopathy is another story, so we'll just end our exercise here. And I hope you enjoyed this lecture, and go and practice on some more cases in the internet. Please do not forget to answer your post-test. We will be sending you an email of your test results and the correct answers. Okay, thank you and goodbye.